Now let's talk about papillary muscle rupture. Now this can be a major complication of either anterior, inferior, or lateral wall MIs. They usually occur around 2 to 7 days after the event. Now there's two papillary muscles in the left ventricle securing the mitral valve. That's the anterolateral and the posteromedial. Now ischemia or infarction to the tissue around these papillary muscles causes necrosis. The chordae tendinae can then separate from the muscle wall, leaving the heart valve without its anchor and thus compromising ventricular systole, reducing cardiac output. The hallmark signs and symptoms you need to know are acute loud systolic murmur and acute mitral regurgitation. You will see an abrupt drop in blood pressure and cardiac index resulting in pulmonary edema and cardiogenic shock. Now remember, as we discussed in the first module, with mitral regurgitation, you're going to see those large prominent V waves in the PaOP waveform tracing, assuming a PA catheter is in place. Again, PCCN, this doesn't apply. Now treatment for a papillary muscle rupture requires surgical repair and a mitral valve replacement. Now, since forward flow is now compromised, you need to reduce afterload. So these patients might be placed on an intra-aortic balloon pump or given vasodilators such as nitroglycerin or even nipride. Now, nipride, this is a vasodilator that releases nitric oxide and reduces preload and afterload. It's given as a continuous infusion and generally indicated for hypertensive crisis. Now, always remember, with prolonged use of nipride, you need to monitor for thiocyanate toxicity. Now, this can potentiate cyanide accumulation, especially with renal patients. So, a quick tip, anytime you hear nipride, you want to think thiocyanate toxicity. You're welcome.